Good afternoon and welcome to today's webinar about diagnosis dementia, now what? My name is Juliana Valencia and I'm a caregiver specialist with Fairfax Area Agency on Aging. You should have received an email this morning with the speaker's slides, so you'll have them for future reference. It is not necessary for you to have the slides open during the presentation because you'll see them. You can also submit your questions, and at the end of the presentation, we'll be asking those questions to our presenter. There is a Q&A box, so please feel free to submit them. Today's presentation is being recorded, and a recording will be sent to all registrants by early next week. There also will be a brief survey as you signed out, so please help us by giving us your feedback. Now it is my pleasure to introduce today's speaker, Lindsay Vajpayee, who is the Director of Education and Outreach at Inside Memory Care Center in Fairfax. Lindsay has dedicated her career to working with older adults who live with dementia and their caregivers. She has certifications in as a dementia practitioner. She's been certified as Alzheimer's disease and dementia care trainer, activity director certification with a specialization in memory care, master trainer with the Best Friends approach to dementia care, and she is a registered Dementia Friends champion. Lindsay is passionate about quality dementia care from professionals, support and education for care partners, and assisting those with dementia to retain a sense of self and purpose throughout every stage of the disease. Lindsay is going to share her knowledge with us today. So thank you, Lindsay, for being here, and welcome.
Thank you so much, Juliana, and thank you all for being here today. Today we're going to be talking about what's normal aging, what's not, a few of the most common types of dementia, and then if this diagnosis has been made for your family, what do we do next? What do we need to be thinking about? So let's start with what's normal with age. You know, our brains change as we age, just like our bodies have changed. So you might walk into a room and think, what did I come in here for? But then a few moments later, you remember and you can complete that task. We might misplace things from time to time. We might forget an appointment, make a bad decision once in a while. You know, but these are not things that are really getting in the way of our everyday life in any significant amount. But then there are warning signs of things that are not normal with the aging process. And this is a list of 10 warning signs from the Alzheimer's Association. The first warning sign being memory loss that disrupts daily life. You know, not just like I forgot to pick up some milk on the way home, we all do that, but really forgetting important information that's been recently learned, you know, entirely forgetting that a conversation took place. Maybe that person is asking the same question over and over again or telling you the same story multiple times within that same conversation. Another warning sign would be challenges in planning or solving problems, you know, deciding what to do and what order to do it, and how do I handle any problem that might arise. A third warning sign, difficulty completing familiar tasks. So things like driving to familiar locations, paying your bills, setting up your doctor's appointments, you know, using the microwave, using the remote control, those sorts of things. The fourth warning sign is confusion with time or place, you know, really becoming disoriented to the seasons, the passage of time, days and nights, or becoming really disoriented when in new locations. The fifth warning sign is trouble with visual images and spatial relationships. You know, so yes, our eyes may change as we age, but this is really more about how the brain is interpreting all of this information that our eyes bring in. So what you see in this warning sign tends to be changes in the ability to distinguish like depth perception or color contrast. The sixth warning sign, new problems with words in speaking or writing. Difficulty with word finding, keeping up in conversation, being able to write and understand written material. The seventh warning sign is misplacing things and losing the ability to retrace steps. You know, we all lose things sometimes, but this is when, you know, you really can't walk backwards in your mind and figure out where that item probably is. The eighth warning sign, decreased or poor judgment. And again, we might all make a bad decision once in a while, but this is when it really starts to become a pattern. It's really starting to get in the way of everyday life. Maybe falling victim to multiple scams, giving money to people who you wouldn't normally give money to or couldn't afford to give that sum of money to, just really significant changes in judgment. The ninth warning sign is withdrawal from work or social activities, pulling back from engagements with friends and family, maybe retiring earlier than anticipated from employment, pulling back from volunteer responsibilities, really kind of not engaging with others in the way that that person had before. And the 10th warning sign is changes in mood or personality, which could be becoming more confused, more irritable, more fearful, more anxious, changes from that person's baseline, what would be considered normal for them. And with any warning sign, there are so many reasons why this might occur, but one of them could be that there's a change in cognition. Now, before we talk about dementia, let's mention the term mild cognitive impairment, MCI. MCI is technically not a type of dementia. MCI means that there is a memory or a cognitive problem, where this person is not performing at the level that would be expected of their age group, but this cognitive change is not significantly interfering in daily life. It's not getting in the way of that person's ability to participate in daily activities. So yes, we might notice a memory problem that's more than what's normal for age, but this person is still able to go about their daily routine, and this isn't interfering, in any significant sense. However, when someone is diagnosed with MCI, it does increase risk for developing Alzheimer's or later on being diagnosed with Alzheimer's or another form of dementia. So on this chart, we see MCI there in the middle. Cognitive changes are occurring, but they're not getting in the way of everyday life. As things continue to change in the brain, for some people, that MCI, is really just kind of the precursor to dementia, where now these changes are getting in the way of everyday life. But I also want to point out to the left of MCI, you see preclinical, that there are changes happening in the brain for years and years before any symptoms are noticeable on the outside. And we see there at the top, normal aging. Yeah, maybe a little bit of change with age, but certainly not to the extent of this MCI and possibly dementia. So what is dementia? Dementia is not one specific disease. It's just this umbrella term. It's a general word that we use to describe a group of symptoms that may affect memory, thinking, language, social abilities, other kinds of cognitive functions. And these symptoms are significant enough that they are now getting in the way of everyday life. They're compromising this person's ability to, to live independently, to make good choices, to take care of themselves, to engage with the world in the way that a healthy brain, healthy aging adult would normally be able to do. And sometimes we call dementia neurocognitive disorder. So what's required to receive this diagnosis of dementia? When we talk about dementia, it means that there's an impairment in at least 2 cognitive domains. So mild cognitive impairment, there might be an impairment in one cognitive domain, for example, just memory. In dementia, now we're talking that there's changes in at least 2 areas. So that might be memory and judgment, or language and visual spatial ability. Generally memory is one of them, but that may not be the first symptom for some forms of dementia. But we're talking about changes in 2 areas or more of cognition. So I mentioned that dementia is an umbrella term. It's a general word that we use to describe these cognitive changes that are more severe than what's considered normal for age, and these changes are getting in the way of everyday life. So first, let's look at the right side of the umbrella. We see reversible. There are a number of conditions that can cause dementia symptoms, but the condition is actually treatable or reversible. So think about things like a urinary tract infection, depression that's presenting in symptoms that are very similar to dementia. Maybe it's a medication side effect, maybe it is alcohol use, maybe it's a brain tumor. These are things that, if we intervene, could take away some of these dementia symptoms. But then on the left side of the umbrella, we have irreversible types of dementia, these neurodegenerative diseases in the brain. So the most common type of dementia of the irreversible dementias is Alzheimer's disease. And also we're going to be talking about vascular dementia, Lewy body dementia, and FTD today. Alzheimer's is the most common form of dementia. Of all people who have dementia, about 60 to 80% of them have the Alzheimer's type. They have this specific disease happening in their brain. With Alzheimer's, there is a slow, steady path of progression, and it is irreversible. We don't yet have anything that can actually reverse this disease or stop it in its tracks. We do have some medications that are helpful for symptoms for some people, but they're not actually slowing down the progression of the disease. When we think about Alzheimer's disease, we tend to think about short-term memory loss being that first warning sign for many people. That person who doesn't remember information that's recently been told to them, who asks repetitive questions, those kinds of things. But Alzheimer's does not only affect the memory part of the brain. Alzheimer's also has effects on language, on behavior, on activities of daily living, which is things like getting dressed and grooming and showering and those sorts of things. And ultimately, as this disease progresses over the course of years, ultimately it can result in death. When we think about Alzheimer's disease, the onset is most common for people who are 65 and over. Basically, the older you get, the more at risk you become. But there are a small number of people who are diagnosed before the age of 65, and we tend to call that younger onset, or occasionally you'll hear that called early onset. Risk factors for Alzheimer's disease, the biggest risk factor is age. Nothing we can do about that, right? Family history and genetics can play a role in increasing risk, and in a very small number of people, there can be a genetic mutation that is carried down within the family. Head injuries increase risk for Alzheimer's disease, and there are a number of other suspected risk factors, most of which have to do with things like high blood pressure, heart disease, diabetes, also depression. Women seem to be more likely to develop Alzheimer's than men. Older African Americans are twice as likely as older whites. Latinos 1.5 times as likely as older whites. So there are a number of other kinds of factors that seem to influence risk as well. But there are other types of dementia beyond Alzheimer's disease. The second most common type is called vascular dementia. So this is when there's reduced blood flow to part of the brain. There's been a stroke or a series of mini strokes, and all of this damage, little by little, eventually adds up to a significant amount of damage in the brain, and now we have these outward symptoms. So with vascular dementia, the symptoms can really vary depending on kind of the location of these strokes, the severity, the number of strokes there have been. So it may affect memory, it might affect language, it might affect balance, executive functioning. It really depends on the person. Often vascular dementia is linked to underlying cardiovascular or cerebrovascular diseases. And we see this little set of stair steps in the corner on the screen. And this is to remind us that with Alzheimer's disease, we can think more about that chart that I showed you earlier, where it kind of looks like, just a gradual change over a long period of time. With vascular dementia, we tend to see the progression in more of a stepwise pattern. You're right here, and there's a vascular incident, like a stroke, and now you're here, and then it stays right there until there's another vascular incident, and now a change. So the progression looks a bit different than Alzheimer's disease. The third most common type of dementia is called Lewy body dementia. And Lewy body dementia really can mean two different things. It can mean Parkinson's disease dementia, where there are these movement features, symptoms that occur first, and much later on, for some people with Parkinson's, they develop this dementia component. It can also mean dementia with Lewy bodies, where the cognitive changes happen first and some of the movement features happen either at the same time or later. So these two types of dementia are sort of considered 2 points on a spectrum, and together we call that Lewy body dementia. So some of the common symptoms here include fluctuating cognition, inability to retain focus for long periods of time. You might see some of those Parkinsonian features, like a flat affect in the face, maybe a tremor, maybe shuffling with walking. Hallucinations are fairly common, changes in sleep. So they're kind of a whole set of symptoms and characteristics that are a bit different for a person living with Lewy body dementia than for someone who may have Alzheimer's disease. There's another family of dementias called frontotemporal degeneration, or FTD. So this is a group of brain disorders that also share some clinical features, but are slightly different. So some of the common types of FTD are BV-FTD, which means behavior variant FTD, where the primary symptoms are those behavioral changes. You might think about that person who has really no filter anymore, who just says what they're thinking, who has difficulty with impulse control, who may appear more apathetic than they had previously. FTD also has some of these subtypes like PPA, primary progressive aphasia, that are really more focused on the language changes in the brain, that really difficulty with word finding and expressing oneself, or difficulty with receiving information and making sense of that information. So generally, these types of FTD have either behavior or language symptoms primarily. There are some more rare types of FTD that have many more movement features as well. So with FTD, the onset tends to be a bit younger than what we would think about with Alzheimer's disease. Onset tends to be more in like the 50s and 60s, can be as early as in the 20s, or as late as about 80 years old. And there are other types of dementia as well, including Huntington's disease, Creutzfeldt-Jakob disease, Wernicke-Korsakoff syndrome, normal pressure hydrocephalus, which sometimes can be treated, HIV-associated dementia, and CTE. There are others beyond this as well. There are really over 100 different types of dementia. And lastly, some people have what we call mixed dementia, which means they have more than one type happening at the same time. So most often the combination would be Alzheimer's disease and vascular dementia happening to the same person. It could be other combinations as well. Research suggests that a large proportion of people over the age 80 who have dementia may have mixed dementia. So how is dementia diagnosed? There is no one test that can conclusively say if someone is living with dementia and what type of dementia they have. So it would start with a complete medical history. A person would go to their primary care physician, would share some of the symptoms that they're experiencing, and that primary care doctor should have that complete medical history available, and really understand, kind of family history, other conditions that person has had over, their lifetime, and also be able to talk about current lifestyle, current medications, sleep, changes, stress, those sorts of things. There would be that physical examination, looking at things like reflexes, looking at blood pressure, other things that may be occurring, even pain that can cause some dementia-like symptoms. A neurological examination, looking at things like reflexes again. There might be brain imaging, looking for evidence of a stroke or a brain tumor. There might be lab work, looking at, drawing blood, looking at thyroid levels, vitamin levels in the blood, maybe a urinalysis to rule out a urinary tract infection. At some point in this progression, the primary care doctor may refer to a neurologist. So that the primary care doctor may do kind of a brief cognitive screen. They may do some brief mental health screenings, looking for things like depression and anxiety, reviewing medications and such, but they may then also refer on to a neurologist who specializes in this area and thinking about the brain and brain health. And the neurologist may do more of things like neurological examination, brain imaging, possibly with MRI scans, PET scans, or others. And there tends to be a neuropsychological evaluation at some point as well. So this is another member of the team who would do more in-depth cognitive testing. Not just that like 30-point scale, it's going to take 10 minutes, but really testing that takes many hours and looks a little more in-depth at different cognitive functions and how that person may be doing in different areas. But again, there's no one test. It's really these doctors and specialists who are taking each little piece of the puzzle and putting it together and coming up with their, probable diagnosis. We think based on the information that we have, this looks like Alzheimer's disease, or this looks like Lewy body dementia. So oftentimes there's some confusion about the words dementia and Alzheimer's. I hear from people, well, my loved one has dementia, but they don't have Alzheimer's, or, just really not quite understanding those terms. Oftentimes, a person will be diagnosed with dementia first, which means, it's kind of that general word. We see that there are changes that are not normal for age. They're getting in the way of everyday life. And then as time goes by and the doctor can watch the changes that occur, the symptoms, can try different kinds of treatments, can do additional testing, then eventually that doctor is hopefully able to diagnose a specific type of dementia. These symptoms are being caused by Alzheimer's disease or by FTD or something else. So it's important for us to understand the progression of the disease. And each disease may progress differently. So thinking about something like Alzheimer's versus Lewy body versus vascular or FTD, each one will look a bit different. The symptoms will look different. What occurs in the early stage will be different than in the middle or the late stage, depending on the disease. But also each person is different. You could take two people with the exact same diagnosis at the same age, same gender, same education level, and those two people can have very different experiences. So there may be comorbidities that play a role. If I also have heart disease, or if I'm diabetic, or if I have cancer, or there could be other things that occur as well that affect the way this disease progresses and the quality of my life and the treatment options that I choose. But it is important to learn about the type of dementia that your loved one has so that you better understand what's happening, what may change in the future, what treatments might be effective, what kinds of resources might apply to your specific situation. There is a benefit to early detection and early diagnosis. I've had people say to me, well, what's the point in getting a diagnosis, right? There's no cure anyway. There's a fear that people might treat me differently. There's kind of a denial that may take place if I don't hear the words, maybe it's not true. But there are real benefits to this detection and the diagnosis in the early stage. For one, it allows the person living with dementia to be involved in decision making. When they have the most capacity to make decisions, to communicate those decisions, to talk openly with family, this is the time to really include that person in the process and to respect, their wishes, to understand their wishes to the extent possible. With that early detection and diagnosis, it allows for appropriate medical management. What kinds of treatments might be available and when do we initiate those kinds of treatments? If there are other health conditions that occur with that person, having this information may influence the types of decisions that we make for other health conditions. With early detection and diagnosis, it allows for that long-term care planning. What do I want for the future? Who's going to provide that care? How are we going to pay for it? What role are family members going to play? Really to talk about the long term and to have some plans in place. That early detection and diagnosis allows for involvement in clinical trials. So many clinical trials are looking for people in the early stage of the disease, or even before that, with mild cognitive impairment, or normal healthy adults, maybe with some subjective cognitive complaints. So clinical trials are a great way to access experts in the field, to really be part of cutting edge research, to do something that allows you to feel a sense of control and purpose when there's a disease occurring that no one would wish for themselves or anyone else. And this early detection and diagnosis allows for access to resources and development of a care team. Rather than waiting till some sort of a crisis point, we can start learning about resources and get all the right people on the team, well in advance, where we can all work together and tap into all of the things that may be helpful to our family. So I mentioned treatments. There are some medications that can help improve symptoms. It depends on the type of dementia the person has, and of course, the other medications they may take, and possible side effects. But there are medications, particularly for Alzheimer's, that are FDA approved to help with symptoms. So thinking about brand names like Aricept, Razidine, Exelon, Namenda, Nemzaric, these medications may help with symptoms. They're not slowing down the actual progression of the disease, but they can be really helpful for some of the people who take them. But when we think about treatment, we really have to think beyond the pharmaceuticals. Physical and social activity are the two best things that can help that person living with dementia maximize their functional independence, their quality of life, their ability to interact with the world, to be as physically strong and independent as possible. So really looking at that physical and social activity, this is a key part of the treatment, for that person to make their life the best that it can be from day to day. Part of treatment is also equipping care partners with the guidance that they need, the information, and also the support mechanisms that would be useful. So that care partner is really, they're like with the patient there in that care circle. They are an integral part of this team. And again, treatment, getting involved in research may be really beneficial for someone to try new therapies. They may work, there's something to be said for the placebo effect, and also just that more frequent interaction with experts in the field. So if this diagnosis has been made, we want to start the conversation. Who do we need to talk to? What do we need to learn about this? We have to start somewhere. So number one, start by educating yourself and your family about the disease. Take part in webinars like this. Do some learning, attend other classes, do some research online, inquire about books that you can read. Talk to people who have been there too. Really learn. It can be difficult to think about some of these things and to learn about things that are not yet occurring in your life, but also knowledge is power. Not to be blindsided, not to be unprepared, really to have the information that you need to make the best decisions and take the appropriate steps moving forward. If this is a new diagnosis, that's a big decision of when and how to disclose this diagnosis. Who do we tell? How much do we tell? When do we tell? And that's very personal, for each family. Typically, it starts with that primary care partner being involved, like a spouse or an adult child, whoever that caregiver may be. And also, then kind of expanding out to other immediate family members, very close friends, maybe colleagues, and kind of working your way out in a manner that works for your family. We want to start by using effective communication techniques. So even in the early stage of the disease with a new diagnosis, how do I modify the way that I, as that care partner, communicate with my loved one who has early stage dementia? Is it effective for us to start keeping a calendar, a daily schedule, to send a text message that reiterates what I said over the phone? How can I best communicate? We do want to involve the person living with dementia in all aspects of planning while they still have that capacity to do so. and so that we understand wishes and can respect our loved ones' wishes to the extent possible. So really starting the conversation, not just yourself as the care partner or with other close family members, but including that person living with dementia if they have an acceptance and openness to this. We want to start developing a care team. You cannot do this alone, whether you're the person living with these cognitive changes or you're that primary care partner. One person is not enough. You need a team approach. So starting with that caregiver, I really need to think honestly about what are my abilities and my limitations as a caregiver. Physically, emotionally, logistically, geographically, what things do I need to consider? And for the pieces that I need to anticipate I'm not going to be able to fulfill, or I will need some support, who's part of that team? Is it other family members and close friends? Is it healthcare providers like my loved ones, primary care doctor, neurologist? Maybe there are others who are in that circle. Maybe there are organizations, community groups, faith-based groups that are part of our team. Maybe professionals like dementia consultants, maybe social workers, maybe care or case managers, counselors. We want to think about that entire team. Who can I rely on? How do we communicate well as a team? We want to familiarize ourselves with resources before they're needed. Understand what's out there before you're suddenly needing to search for something. We need to make a plan for the future. As much as we'd love to put our heads in the sand, we need to make a plan. One really, really important thing to consider, really early on, after the diagnosis, is what healthcare, legal, and financial decisions do I have to consider for the future? Have I reviewed my finances, my loved one's finances, to understand what are the assets? What do we need to be planning for the future? If there is, we see that now there will be some level of care needed in the future. How are we going to pay for that? How can we position ourselves to be able to do that? What other financial resources might be available to us? And we need to get our legal documents in order. Do we have advance directives? Do we have power of attorneys? Do we have a will or a trust? And you may have those documents in place already. Maybe you drew them up 10, 20 years ago, but you really need to pull them out and see if they say what your loved one still wants. What I put down on paper 5 or 10 or 20 years ago, does that still apply to today? And if I'm the primary care partner, maybe it's my spouse who's been diagnosed, I might have written in my documents that I want my spouse to be my power of attorney. Well, maybe my spouse is no longer in the position to make decisions for me if something unexpectedly happened to me in the future. So it's not only reviewing your loved one's legal documents, but it's taking a look at yours as well. Part of this plan is really learning about the care values of the person who has this diagnosis and the role that those values will play in the future. When push comes to shove, what is most important to me if I'm living with dementia? Is it to be as safe as possible? Is it to not be a burden on my family? Is it to spend time with my family and friends as much as possible? What are those values and what role do those play in the future? What are my preferences for care? Who do I want doing different things? If I need a ride to pick up groceries, I may choose one person, but if I need help in the shower, I may choose an entirely different person. Is that a family member, a friend, a professional? Really talking about these topics again early on while that person has the ability to engage in this discussion. And then not only making a plan, that primary care partner and the person living with this disease, but how do we communicate that plan to the care team? How do we communicate that plan to other family members? There is a program that's available that really helps with this planning process, working through care values and preferences and drawing up a plan for the future. And it's called SHARE. And SHARE is available nationwide. It's a program from the Benjamin Rose Institute on Aging, And there are licensed share counselors all around the country. And at Insight Memory Care Center, myself and one of my colleagues are licensed share counselors. And the goals of the share program are to support both share partners, the person living with the disease as well as the primary care partner, help them communicate as they plan for the future, to promote health and well-being of both share partners, and how do we reduce stress for both individuals. We encourage share partners to take better care of themselves and each other by engaging in activities that they find fulfilling. We learn a lot about community resources that support share partners' values and preferences. And it gives an opportunity to provide some education about dementia and how to manage some of the changes that lie ahead. So this is a really great way for families to work through some of these very delicate conversations together. Now, if the diagnosis has been made, let's say we're still in the early stage, we want to think about how we can manage cognitive dysfunction. One of the things that we might do, kind of a communication tip, is to provide some gentle verbal cues with specific prompts and positive reinforcement. So let's say we're going to be leaving soon for a doctor's appointment. Just giving a gentle reminder about that. Maybe it's, we bring shoes or a jacket over. Maybe we're getting out, a purse and the car keys. We're giving these clues that it's time to be doing something. So not just kind of speaking an instruction like we need to leave in 15 minutes, but starting to put some of those clues and cues in place. And then that positive reinforcement, to really pump that person up, that they feel good about what they can do, and that they're not feeling defeated, that we're not criticizing someone. We're really, praising, thanking, showing that person the respect that makes them feel good and feel a sense of partnership with you. We want to simplify activities and break them down into a little bit more manageable small steps, again, providing some cueing. So for example, instead of heading into the kitchen to go in and bake a chocolate cake on my own, maybe we can break that down into smaller steps. Maybe we work together on that process. It's really helpful to create a predictable, structured routine. It doesn't mean that your routine has to be like on the dot every single day, exact same time, just everything is the same, but some kind of predictable, structured routine is helpful. Getting up around the same time each day, going about the morning routine in the same order, I head to the bathroom, I get dressed, I go downstairs, I take my medicine, I have my breakfast, we read the paper, we go for a walk. Having some consistency from day to day can be useful. We can use distraction and meaningful activities when we see that there are some challenging moments that are starting to arise. You might notice that later on in the day, your loved one is just more tired, more confused than they were earlier in the day. Maybe behavior changes a bit. These are times when we might be able to utilize some distraction, kind of, redirecting attention to a more pleasurable activity, maybe turning on some favorite music, going outside for a walk, and really thinking about meaningful activity, not busy work throughout the day, but how do I help my loved one continue to have a sense of purpose? That they're helping me with household tasks, that we can volunteer together outside the home. And maybe your loved one is part of some type of a structured program away from home during the day. We want to think about telling that person what they need to know when they need to know it, and not too much information and not too far in advance. Inform the person of events only as they occur. So instead of saying, Susie's coming to visit us next week, we need to start getting ready, that person may have some difficulty understanding how far away is next week. And you may hear every single day from now until next week, is Susie coming today? We have to get things ready. So maybe instead I would say, the day before, Susie's coming tomorrow. Or let's say your loved one has a doctor's appointment. Instead of saying the doctor's appointment is tomorrow, maybe I say in the morning, in a couple hours, we need to leave for the doctor's appointment. And I don't say something about it so far in advance. Really thinking about when am I giving information and how much information am I giving? And even in the early stage, we want to start addressing difficulties with IADLs. That means instrumental activities of daily living. This is things like driving, paying bills, setting up appointments, grocery shopping. You may notice your loved one is starting to have some difficulty in these areas, and really thinking reasonably about how I can support my loved one, and also when it's time to transition away from some of those activities, like driving. Just receiving a diagnosis of dementia doesn't mean that someone has to suddenly stop driving, but we know that these are progressive conditions, and there will come a day, sooner rather than later, when it isn't going to be safe to do something like driving. So really starting to address those with the person, with the doctor, with the family, with understanding resources that are available to you. You want to start considering environmental changes in your home. Maybe removing clutter. When there's too much clutter in our environment, it can cause additional confusion. Maybe I go down to the kitchen to make coffee in the morning, but if the kitchen counters are covered with other stuff and the coffee's in the back of the cupboard, I can't find it, that is not supporting my independence. But if we can remove some of that clutter, if the coffee is right there at the front of the cabinet or sitting right there on the counter next to the coffee pot, I may be able to be more successful. We might consider using some labels or visual cues in your home environment. Maybe it's a sign, like a picture of the toilet on the bathroom door. Maybe it's a label, on each dresser drawer, pajamas, underwear, pants, those sorts of things. You might consider now changing the tools or the materials or the equipment that your loved one uses in activities. So think about what your loved one likes to do. Do they like to paint? Do they like to garden? Do they work on the car? Do they do photography? And how might we need to adapt in this area? Do we need to change the type of equipment that's available so that it's safer, more user-friendly? Do we need to provide a little support with just making sure that the materials are readily available? Just kind of modifying the activity as needed as the person changes. And we might modify that physical environment, making sure there's plenty of lighting, that we keep some of the noise levels down, all of that extra noise like from the TV or the radio or noises coming in from outside or lots of conversations that are happening around me at like a big event, that can be really overstimulating. So how do we need to modify the physical environment to support the person living with this disease? We want to address depression and apathy, especially in the early stage for that person who understands the extent of their impairment. They see how things are changing. They may feel worry or grief or frustration about these things. They're more likely to be depressed over their losses. So really addressing this, really watching for signs of depression, talking with that person's doctor, making sure the right kinds of supports are in place for your loved one. As dementia progresses, there may be a bit less self-awareness, being aware of the extent of my impairment, but it may be more apathy at this point, as we get into the middle and later stage of the disease. Apathy is also really common in FTD, even in the early stage of the disease, just because of the way, the area that the brain is changing. So these are really important things to talk about with your loved one's physician. Finding support is a really, really important part of planning for the future and managing the day-to-day. Both support for the person living with dementia, but also yourself if you're that primary care partner. And who is my source of support? Is it a community resource? Maybe it is a support group. There are support groups through the Fairfax Area Agency on Aging, support groups through Insight Memory Care Center, and many, many others as well. Maybe it's consulting with a professional, thinking about a counselor, a therapist for your loved one and or for yourself. Maybe you consider hiring some help in the home. Even if your loved one doesn't need hands-on assistance for themselves, you might consider bringing in some support with maybe housekeeping or with cooking or with lawn care or with bill paying or some other areas to help reduce some of the burden that is starting to shift more onto your shoulders if you're that care partner. We want to think about safety at home. How do we secure safety? How do we think about Again, changing that physical environment. Maybe it's thinking about cameras in our home or doorbell devices, or having like a medical alert bracelet or some type of a GPS tracking device on a cell phone or in a car. Really thinking about how do we make sure we have all these pieces in place so that I can feel supported and secure as the caregiver. And we want to think about finding housing with supportive services. Not necessarily to be utilized now, but just to be more aware of what's out there in case it's something that we need in the future. And caring for yourself. This is really like rule number one for being a caregiver, is taking care of yourself. It's easier said than done, right? But if I don't care for myself and I get sick and I'm in a bad mood all the time and I'm not sleeping well and I'm losing weight or I'm gaining weight and all these things are changing, how can I possibly meet my loved one's needs? Work and caregiving can be really stressful. So this may be something that needs to be addressed. Do I continue to work? Do I have a flexible enough job? Do I have benefits that we need? Can I change my hours? Can I change my responsibilities? What impact does that have on us financially? What impact does that have on my own emotional health and social outlet? You may need to advocate for yourself. You have to be that squeaky wheel that doesn't just say, what your loved one needs and you're an advocate for them, but what do I need? I need a break. I need a family member to come over on Saturday afternoon so that I can have a little alone time, so that I can go get my hair done, so that I can have coffee with a friend, that you get what you need to. Recognize your emotions. This is hard. It's hard for everyone involved. It's hard for your loved one, and in different ways, it's hard for you as that primary care partner. And how do you feel about that? And who can you talk to about that? Is it a friend? Is it a support group? Is it a therapist? Really not shoving those emotions down and pretending they're not there, but how do I recognize them? Let those emotions flow through me, develop some coping strategies to help in these difficult times. Part of caring for yourself is living a healthy lifestyle, getting some exercise every day, getting enough sleep at night, drinking plenty of water, eating healthy foods, having social outlets. These are all really important things for you to take care of yourself, again, so that you can be present and be the best caregiver you can for your loved one. And really learn about caregiving services in your community and support groups. So some of those resources for you, Fairfax County's Area Agency on Aging has some wonderful resources that I hope you will look into. These webinar series, respite programs, support groups, consultations, and many other things. Insight Memory Care Center can be a resource to you as well. Our Adult Day Center for those living with dementia, our early stage programs, including the SHARE program. It may be support groups, classes, memory screenings, consultations, memory cafes, or lots of other resources that we can help connect you to as well. The National Institutes on Health actually has some really great resources about Alzheimer's, about caregiving, about brain health. So I encourage you to check those out, sign up for some of their emails that come out. They're really informative. And then if you wanted to learn more about that SHARE program, you can find that on the Benjamin Rose Institute on Aging website. And again, at Insight, we have a variety of services, not only to support the person living with dementia, but also family caregivers. So please feel free to contact us if you have any questions after today's class, if you are interested in any resources that support either of you. My phone number, my email address are there on the screen. I encourage you to reach out, to start somewhere. Once you kind of get that ball rolling and you learn about resources and you start to develop a plan, the rest really starts to fall in line from there. It's just taking that first step. And now I'd like to open it up to Q&A.
Thank you, Lindsay, for such a wonderful presentation. Very informative. We do have a few questions from our audience. The first question says, is exposure to agents such as Viet service in Vietnam a known factor in any or some of the types of dementia?
Yes, Agent Orange has been connected to Parkinson's disease. And for people who live with Parkinson's disease, about 50 to 80% of those will eventually develop Parkinson's disease dementia. So I'm not familiar if there's any connection to some other types of dementia like Alzheimer's, but definitely there has been a connection to Parkinson's and Lewy body dementia.
Thank you. Our next question says, how do you manage autonomy of the person versus safety of the person who has dementia?
Great question, right? That's a hard one. It's very, very delicate to walk that fine line between, my loved one wants to be independent, wants to do things for themselves, feel good about themselves, but also safety. My loved one wants to drive, but I'm starting to question if that's really in their best interests. So sometimes having outside sort of unbiased experts come in to help make determinations takes some of that burden off of you as the care partner. If the doctor makes a recommendation, or for example, with driving, a driver rehabilitation specialist makes a recommendation, that takes some of that burden off of you of kind of being the bad guy. And then looking for every opportunity that you can to give that person a sense of control. So let's say your loved one isn't driving anymore, you're taking them where they want to go. When you get in the car, instead of saying, okay, well, I think we're going to go here, here, and here, ask your loved one, where do you want to go today? Where do you want to go first? Really giving them as much sense of control as possible. Thinking about making choices. Choices can be hard. So instead of saying something like, what would you like for lunch today? Which is just such a big kind of ambivalent question. Your loved one might be able to be more independent in decision making if you gave two options. Would you like some salmon, or would you like a burger for lunch today? And when you give choices, your loved one may be able to select a choice and feel that sense of autonomy rather than someone else is making all decisions for me. But it is tricky. No doubt about it. And that's, I think, where especially participating in support groups can come in really, really handy to hear from other caregivers and how did they walk this really fine line that it almost feels like, I don't know if quicksand is the right analogy, but it's like it's always changing. Whatever I decide today, in a month or in 3 months, that might not fit the situation any longer. So how do I adapt? How do we both adapt?
That's true. That's true. Thank you for that. Our next question says, when the doctor reports infarcts in the brain from a stroke, is that considered the beginning of stage of dementia?
So having a stroke may or may not have cognitive change symptoms, right? It depends on how many strokes there have been, where they are in the brain. So for example, my grandmother had vascular dementia. She had from around the age of probably 80, she started having mini strokes, not every day, but over these many years on a fairly regular basis. And then around the age of 90, she really started developing these cognitive changes because of the damage of all of these little strokes. But for someone else, it may be very different when they have kind of a major stroke rather than these TIAs. The changes may be much more apparent very quickly. So having a stroke having a stroke doesn't mean there's dementia. It kind of depends on the symptoms that are emerging after the stroke.
Yeah, very important, I guess, to have that communication also with care providers, right? To understand what's happening with the brain.
Exactly. Really, whoever's reading the images, who's like, if it's a primary care doctor or a neurologist or a cardiologist, whoever's identifying these infarcts in the brain, these evidence of strokes, what does that mean? What does that mean in practical terms, right? And being able to have that conversation to know, okay, well, this is why my loved one needs help in this way or acts that way, or we see that there's a stroke, but really there's no symptomatic effect of that.
Very good. Our next question says, how crucial is it to get a specific diagnosis of which kind of dementia it is? My partners have been a puzzle to medical professionals for 14 years.
I think it's really, really helpful to have that specific diagnosis. We call it like differentiating a diagnosis, right? Is it Alzheimer's? Is it FTD? Is it maybe a more rare type of dementia? But there are some times when it just is either like a mystery. We've been trying, we've been seeing multiple specialists, we just can't quite come to a conclusion about that. Or maybe your loved one is in very frail health and going through all the steps, all the brain scans, all the specialist appointments, maybe that's not going to be in their best interest. So there are some times when maybe it just doesn't make sense to pursue that specific diagnosis. But generally, I find it very helpful to know. It helps us understand symptoms. It helps us, look to the future a little more. It helps us understand what treatments might be effective or might not. So when it's possible, I definitely advocate for getting to the bottom of it, right? Getting that specific diagnosis, but it's not going to work 100% of the time.
That's true. Our next question says, any recommendations for dealing with a parent that stays up all night? She also has sound downing, very aggressive and confused in the late afternoons.
Yeah, so I mean, these changes in sleep are pretty common for somebody living with dementia, especially as the dementia progresses. That person's like circadian rhythm, their brain's ability to regulate that sleep cycle may change. And that's really hard for that care partner, right? I need to sleep all night so that I can be awake and functional during the day to support this person. Some of the things that you might try doing to help with these sleep changes would be to have, again, that very consistent structure throughout the day that includes some active times, like having some physical activity every morning, every afternoon. Also having some rest time. If your loved one is sundowning, let's say later in the afternoon or early evening, they're really becoming confused, their mood is changing, they're becoming, maybe more aggressive or irritable. I might need to think back, did we have too busy of a day? Was there too much stimulation? Maybe after lunch, we should have rested for a couple of hours, and providing that consistency. Also thinking about things like caffeine, are we drinking caffeine too late in the day? Is there pain that's not being managed? Maybe my loved one is, irritable later in the day because their back is just killing them, or in the middle of the night, laying in bed is really hurting. So talking with the doctor is an important piece too, to identify if there's like a physical, something that's going on that person can't express. Do we need to get on top of pain? Do we need to change a medication? Or is it more, psychosocial? Maybe how do we have more engaging, fulfilling activity during the day so that we do have that kind of sleep well at night? And I do encourage you to, to really talk with someone about that, whether you contact me after this, you talk to your loved one's doctor, really to help kind of work through some of the specifics and come up with a plan of, well, what are we going to try? What can we do in this situation? And for some people, it's sort of a phase of the disease, these sleep cycles really changing, and it might mean bringing some help in for those hours of the day. If that's a possibility for you, maybe we hire someone to come in the evening or the overnight so that you as the caregiver can get the sleep, and the things that you need.
Yeah, very important that the caregiver is well rested and taking care of himself or herself to be able to continue to provide that care for their loved ones. So our next question says, can having other health issues like renal failure speed the process of dementia setting in?
Having these comorbidities, if you have renal failure, if you have a heart condition, if you have something else, it can affect brain health. It can affect sort of the lifestyle, like the amount of physical activity and socialization. It may affect treatment decisions. So there can be an effect. It's really a case by case kind of thing. How much of it is this other condition that's affecting cognition? How much of having this other condition really guides us in our routine, in our treatments, and our decisions for the future? So, most older adults don't have dementia in a vacuum, right? It's still somebody who might have renal failure, has a heart condition, has diabetes, may develop cancer. There are other things going on too. And it's, this is part of that care team really communicating well together, understanding how each person plays a role and how any decision that any one part of the team makes, how does that affect the entire picture?
Right. So important. We're approaching the end of the hour, but we still have a couple of minutes. And we have more questions. So let's see if we can get another one in. Do you have tips for what to do for family members with dementia and what to do with the phone scams? They always answer the phone and fall into scams and do not have savvy tech skills, I
Yeah,
guess.
right. So one of the things that I've heard family members do is turn off, like if it's a landline phone, you might turn off the ringer. If there are times when you're not available to answer the phone, but you think it might ring, if you're leaving the house or you're going to be in the shower, you might turn off the ringer so that it just goes straight to voicemail if someone calls and your loved one won't pick up the phone. It's hard because as much as you might say, okay, if somebody calls, don't give them your credit card number, don't give them your social security number. In the moment, I mean, even healthy adults can fall victim to this, right? And so when there's impaired judgment and, it's really easy to fall victim to scams. So thinking about, not that you don't want your loved one to have access to the phone if they're capable of using it, but how do we try to stop some of these calls coming in? I mean, you can add that number to, what's it called? There's like a do not call line, solicitation. I forget what it's called. I mean, you can add that number to that, but still I've heard, even if you do that, scammers are crafty, right? And the calls continue to come in. So that is definitely a tricky area. Sometimes it might be reducing access to that personal information. Maybe it's not just leaving the wallet right there where your loved one can access it. Maybe it's somewhere else, but that's definitely a tricky situation.
Absolutely. And also, I mean, if you are the power of attorney, the financial power of attorney, you can always act on it and go to the bank and take different measures or report it to Adult Protective Services, who can also help them navigate and reach out to other resources. Thank you, Lindsay. This has been so informative and so good. So we are ready to wrap up. And as you signed out, there will be a brief survey. Please take a moment to answer those questions and help us provide topics that you are interested in. We do have 2 more webinars scheduled for this year. Our next webinar will be on Medicare, and it's Medicare 102, and it will be on Wednesday, October 28th. So you're all welcome to join us on that day. Lindsay, thank you for the information that you provided today. It's so valuable and so important for family caregivers. And I want to thank our audience as well for submitting their great questions. And I hope you all have a great afternoon. Thank you. Bye.